Hello to everyone. I'm Fabio Taccone from Brussels. And within the ISISM chats, I have the great pleasure today to welcome Professor Luciano Gattinoni, worldwide very expert in the mechanical ventilation and ARDS. And first, I thank Luciano for accepting the invitation to discuss with us. And the topic today will be individualized ventilatory management in patients with ARDS. And as you know, as the chat is only 10 minutes, we will focus a little bit on the patient on controlled ventilation. So Luciano, I would like to start for the first question with you. Everyone claims we need to use tidal volume 6 milliliters per kilograms ideal body weight. Is this true for all ARDS patients on controlled ventilation? Or can we adjust this using parameters like delta pressure or something else?
Well, I think that the best normalization of tidal volume should be not on a body weight, but on the lung weight, because I may have a 70 kilo person with a lung FRC, which is half a liter, 1 liter, 1 liter and a half, with a very bad PO2, so it doesn't make any sense. 6. I think the study just suggested that in general, in ARDS, you have to treat the lung more gently as you can. This is the message. But 6 versus 7, 8, and so on, we have several studies before the ARMA study telling no difference between 7 and 11, 8 and 10, and so. So if you want individualize, you have to individualize. That means, to me, the best way would be to measure the gas lung volume at FRC or at 5 of PEEP, something like that.
Okay. And is there anything else that people can do? There would be another surrogate if people cannot measure FRC?
Well, a surrogate maybe, I think the delta pressure, the delta pressure, the driving pressure is closer to to what you want, because the driving pressure is a sort of equalization of tidal volume for lung compliance, and lung compliance is related to the gas volume. So it is a cycle. So to answer is a best tidal volume or driving pressure? I would say driving pressure. But believe me, you have to also to be careful on what kind of PEEP you are using, because a driving pressure of 10 with PEEP 0 or PEEP 5 or PEEP 10 or PEEP 20 is a completely different effect. So you don't have to look one number. You have to look at the entire picture of the patients.
So thanks for introducing the concept, because one of the rules of ARDS is, of course, setting up the PEEP. And some people say more than 15, there is a risk for increased mortality. Do you think that there is a rule, and how you would set up the PEEP at the bedside in these patients?
Well, ARDS, if you speak about the syndrome, remember that all this data has been drawn from a general population. What is the general population? In all this study, I think 80% of the people had or bacterial pneumonia or sepsis. As an example, COVID, which is a pneumonia, but is not bacterial pneumonia. COVID, at the beginning, the gas volume is 2 liters, 2 liters and a half. Doesn't make any sense to have the PEEP, which, or the tidal volume, which was derived for the study. What's about PEEP? What we know about PEEP? When you have low PEEP, we have a risk of so-called atelic trauma. When we have high PEEP, we have a risk of volotrauma. So we have comparing lower and higher PEEP, we compare volotrauma versus atelic trauma risk. What we know? With all the study we have done, we saw that the risk and benefit of atelic trauma or volotrauma between 5 and 15 of PEEP are equivalent in the general population. In a general population, if we go greater than 15, wins the volotrauma is worse. It's quite simple. This, and remember that when you use overcome 15, is asked to ventilate the lung, which start to be close to its own total lung capacity. Try to take a big breath And now try to imagine to ventilate on this condition. This is what we do when we have a very high PEEP. Very high PEEP at the beginning of COVID, as an example, to me may be devastating. Means renal failure, means a lot of fluids, blah, 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 and so on. And,
of course, Luciano, I fully agree with you, and it's nice to have the discussion, but some people claim that, for example, you can adjust the PEEP using, you have been made many studies using CT scan at 2 levels of PEEP. People can maybe claim using bedside monitoring like electric impedance tomography. Is there a way for people to do that at the bedside again, something that is feasible, not too much complicated?
Well, what is feasible? The general rule with PEEP, I think, for what we know, remember, between 5 and 15 is the same. And the people say, okay, but I'm very worried about the gas exchange, the PO2. And if I use IPEEP, the PO2 goes up. Of course, in 95% goes up. But with which mechanism? Recruitment or just depression of the cardiac output? You know, we cannot speak about gas exchange without considering together hemodynamic and respiratory mechanics.
Okay.
Is deeply wrong. And of course, it's easier to oxygenate 1 liter of blood than 5 liters, right?
Absolutely.
So all the people who look at the gas exchange to set people, to me, is simply wrong. That's it. So then the people can do whatever they want. I mean,
it's perfect, because the point of gas exchange introduced the third question, which is FiO2. Many people use, you know, the scale with the RDS-net trial, whatever. How do you set up the FiO2? Is it a matter of gas exchange, or is it based on or something else, like the minimum toxicity or potential toxicity?
Well, you know, my generation was grow up with the concept in the 70s, 80s, the devil was not the barotrauma. The devil was the oxygen toxicity. And even the first study of Zephyr on ECMO were designed to decrease FiO2, not to change pressure. Okay? But then the story of FiO2 disappeared completely. Just in the last few years has been reconsidered. I think that when we do not know really the answer, we should apply the Latin proverb, in medium stat virtus. That means the thing to do are in between. Not very low, 21, not very high, 100%. So I think between 40, 60 are more than acceptable. But once again, when you speak about gas exchange, you cannot ignore hemodynamics. Because I have a 40 PO2 and 7 liters cardiac output, I don't have any problem.
Of course.
In terms of oxygen transport. So look always to the
hemodynamics. I have another question on gas exchange, which I find it very interesting at bedside, concerning PaCO2, and which of course makes the question about respiratory rate. So many people adjust low tidal volume, increase respiratory rate to correct pH and PCO2. And my question is, when you set up the respiratory rate, is it a target of CO2, or should we look at something else?
I think usually for a PCO2, we look at the total ventilation. The respiratory rate is completely ignored. But let's see that each tidal volume is as a sort of shot with a hammer. If I give a hammer on the table once per minute, 10 times per minute, or 40 times per minute, what is better for you? Respiratory rate is a part of the possible damage. And we introduce the mechanical power, which is not very complicated. The mechanical power is just to put the danger of the tidal volume plus the frequency, plus the starting point, which is the amount of PEEP that you are delivering. So it's a quite simple, it is not a magic number, it's a concept. Tell you that when you have to do the mechanical ventilation, you want to do gentle treatment of the lung, you have to consider the entire picture, and the frequency is extremely important.
Luciano, I have, of course, an observation from a non-expert. Sometimes we set up the tidal volume, the PEEP, we don't care enough for respiratory rate, and if you calculate the mechanical power, you have an elevated, more than 22, which is the cutoff associated with the... So in this case, would you reduce the respiratory rate and accept an hypercapnic acidosis if it is
Absolutely,
tolerated?
yes. Absolutely, yes.
Or would you use respiratory rate lower value and you would apply some extracorporeal CO2 removal? You will not tolerate hypercapnic acidosis at all.
It depends by the general picture, because I'm convinced that for some patients, the safe ventilation simply does not exist. You can manipulate as you want, it's not tolerable in terms of a viable gas exchange. At this point, I introduce the ECMO support. And the people that continue to look at the ECMO and so on, looking at the oxygenation as entry criteria. Now look at the Eolia. And you have oxygenation in the treated, oxygenation in the control is exactly the same. PCO2 is a larger difference. PCO is fundamental because PCO2 tell you the real status of the lung, far more than oxygenation. When you have a high PCO2 continue to rise, means the lung architecture is changing. It's not just a wet lung collapsing, bad oxygenation, but I start to break the alveolar walls, I close the capillaries and so on. So and the PCO2 to me is when I have to take a phone and have a news for the patient, the first thing I ask, how much is the PCO2 and how much is the total ventilation? Did give you like this, what is the patient condition?
I have a very last question because unfortunately we already at the time and I will discuss with you for hours about this. It's just a very specific question. Many people talk about prone positioning and the prone positioning is selected basically on a PF ratio. Do you think that PF ratio is the only way to select a patient's candidate for prone positioning, or we should look at the lung mechanics and which parameters we should look at?
I mean, the prone position goes, PO2 goes up. Good. Okay, so it may be an indication, but why the prone position improve the survival in classic ARDS? Not because of oxygenation, but because of the change, the stress-strain distribution, the mechanical forces distribution. So just to have a very simple statement, if the lung is compromised, whatever bad you do to the lung with your ventilation is less bad in prone position than in supine. That's it.
It's a very clear, wise response that I hope people will use to identify better these patients. So, Luciano, a big thank for myself and of course EasySem to having been with us. And we hope to have you soon for a next discussion about everything that you would like to discuss with us. Thanks a lot.
Fabio, it's been a pleasure. See you, everybody. Bye-bye.